Within the medical community, there has been a greater focus on what happens to patients outside the four walls of a hospital or clinic. A person's socioeconomic status, education, social context, access to healthcare, and where they live are all contributors to what are called the social determinants of health.
The social determinants of health, for anyone that has been in this area, is really the causes of the causes. It's those things that cause healthcare to be poor, cause health outcomes to be poor. Let's give you an example. It's everything from the environment, education, travel, housing, all of those things are social determinants of health. But there's also a new one that I like to refer to, and that's the digital component, because today, technology and the internet is just as important as those other things.
Everybody's using it. Some people don't have as much access to it, right? Many kids, unfortunately, have to sit up against walls, against libraries to get the Wi-Fi access to do their homework. So there is a digital divide out there.
Telehealth and some of the wearables and home monitoring tools provide patients the ability to take care home with them and to monitor without having to find transportation back to the hospital to get their blood pressure checked. They can now do those types of preventive care measures at home. So that provides a convenience for all of us as patients and for everyone who needs care. But we still have to make sure that we're not just throwing technology at healthcare, that the technology we develop is actually making a difference, that it is increasing preventive care, that it is improving access to healthcare, that it is improving patient outcomes versus here's another technology solution, start using it. How does that contribute to the overall health improvement of our patients?
In the world of digital health, the old saying, "Build it and customers will come," is quickly getting overturned. There is an increased focus in including the communities that you are serving and designing for.
We know that we're humans, so although technology is amazing and it's an opportunity, if we build in those same human biases or beliefs, you're going to create the same kind of barriers to care. Some communities, when you call in and say you're pregnant, they ask you if you're 8 weeks pregnant or not. And if you cannot articulate yes, if you say, well, I'm not sure or not yet, then they say call back when you are. Well, that right there assumes a lot. It assumes that we teach sex education in this country, which we do not. It assumes that people know what 8 weeks pregnant even means, but also it creates a barrier, right? So once we decrease that barrier, that bias around the belief that certain people should wait to come in for care, because we also then penalize people for showing up late to care. So we say, oh, folks don't want to come into care. So how amazing it would be to have a platform that people would know what 8 weeks meant. So even though we don't want that to be the case, but if that were a real thing that we want people to wait to 8 weeks, we would have an opportunity to share that information.
According to the World Health Organization, every day, 810 women die from preventable causes related to pregnancy and childbirth. 94% of all maternal deaths occur in low and middle income countries, according to WHO. According to the CDC, Black infants are dying at a rate of 10.8 per 1,000 births, compared to white infants that die at a rate of 4.6 per 1,000. The health disparities associated with maternal and infant mortality are now getting national attention. In fact, Vice Presidential candidate Kamala Harris has spoken out about the issue.
The facts are clear. Black women are 3 to 4 times more likely to die in connection with childbirth than other women. The facts are clear that Black women are 60% more likely to have preeclampsia than white women. The facts are clear that a Black woman with a master's degree or higher is likely to lose her baby before their first birthday more than a white woman with less than an 8th grade education. The facts are clear. College-educated Black women are more likely to suffer complications from pregnancy and childbirth than white women who never graduated high school. These tragedies are occurring to Black women regardless of socioeconomic status, regardless of educational level. We all remember how Serena Williams courageously told her story. The reality is that when a Black woman walks into a health clinic, a hospital, or a doctor's office, she is not taken as seriously.
Today we are seeing members of Congress stand up and take action. For example, North Carolina Congresswoman Alma Adams has worked on acts to help improve funding for training programs to reduce racial bias in the maternal health space, as well as launching the Maternal Black Health Caucus.
In 2018, Senator Kamala Harris and I worked with the Black Mamas Matter Alliance to introduce the Maternal Care Act, which would provide $25 million to fund professional training programs to reduce racial bias among our healthcare professionals. This important work led to last year when Congresswoman Underwood and I launched the Black Maternal Health Caucus. The main goal of our caucus is to develop and advance evidence-based policy solutions to the issues impacting maternal health. With the support of our incredible stakeholders and caucus members, this year, Representative Underwood, Senator Harris, and I introduced the Black Maternal Health Momnibus Act of 2020, a package of 9 bills that build upon existing maternal health legislation to comprehensively address the Black maternal health crisis. The Momnibus makes investments in training providers and professionals to screen for social determinants of health. It helps to diversify our perinatal workforce and invests in doulas and midwives and lactation consultants. And the Momnibus invests in telehealth services, digital tools, and increased data collection to help increase access to care and develop targeted solutions.
One of the key elements to making real change is having a diverse workforce and representatives that look like the community that's being served.
It is being comfortable. It is being able to have a voice. And when you have a voice, that voice is able to say, this is how I feel. Because sometimes you don't feel comfortable saying it to you, but they may feel comfortable with saying it to her.
Social determinants of health is becoming a conversation around the world. And today, these issues related to access to care are being tackled by partnerships and collaboration.
You don't operate health by borders. In other words, a person in the smallest village who has a virus like a COVID-19 or some type of ailment, it crosses borders. So this idea of, it doesn't come from your country into mine, that's been a big shakeup in understanding. And what we've come to realize is that you can't leave anyone behind. If you leave one person behind, you pull everyone behind. So this is a bottom-up lifting, if you would, that every single person has to have access to quality care. And the regulatory environment that stops caring of one border to another, whether it's country to country or just in the United States, where you need services of someone late at night, and that particular physician or specialist happens to be across the border from you, that would have stopped the care from occurring. And now we've made special regulatory compensations in the short term that allow cross-border care to exist. I think these types of things will continue to expand.
Maternal mortality and COVID-19 aren't the only places we're seeing health inequities. In fact, this has been a discussion for generations. Today, many organizations like HIMSS are creating different programs to address the issue. Last year, HIMSS launched the Global Health Equity Network to advance the causes of health and wellness for everyone. Thank you for watching HIMSS TV's Deep Dive. I'm Laura Lovett, signing off.